Rajim. I start the CME with the name of Allah, who is very beneficial and merciful. The topic for today by the Mother and Child Survival Group of Pakistan of CME is an eclampsia. Before we go into the details of eclampsia, we will just introduce you to pregnancy-induced hypertension, which is basically the high blood pressure in the second trimester, which is 130/90, 2 times of 2 weeks apart. If this is the case, then it is the pregnancy-induced hypertension, not in the first trimester. In the first trimester, the hypertension could be due to chronic hypertension, renal hypertension, and other secondary hypertensions. The pregnancy-induced hypertension, if it starts leaking albumin, which is very much likely, and then it causes albuminuria, and then there is retaining of albumin in the body, hypoalbuminemia, then it is known as preeclampsia. And then when it persisted on uncontrolled hypertension with leaking of albumin, then it goes into fulminant preeclampsia with the warning signs. And what are the warning signs? This is pain epigastrium, severe headache, vomiting, nausea, pain in the epigastrium and in the right hypochondrium, diplopia, double vision, and other things are there. So this is the warning sign that the system is going into a very next phase, and that is the very life-threatening phase, which is known as eclampsia. Eclampsia is basically a life-threatening condition characterized by convulsions, fits, seizure, unconsciousness, and high blood pressure and albuminuria, and in the fulminant setting of preeclampsia. It has to be dealt. It's a medical emergency, and any patient who arrives in the emergency with fits must be thought of this eclampsia. The other things, that is gestational epilepsy and other causes like septicemia, meningitis, encephalitis, cerebral tumors, CVAs, they can be considered later on. But in pregnant, it is the dictum that you must follow this, that any pregnant patient come with this, so must think of eclampsia. And a brief review management of this serious life-threatening condition, which can cause cerebrovascular accidents, thrombosis, tumors, embolism, and then DIC, disseminated intravascular coagulation, the death of the mother and the babies, and the increase in the morbidities like intrauterine growth retardation, and then nephropathies and DICs, nephropathy, renal failure, and HELLP syndrome. These HELLP syndrome is basically uncontrolled hypertension, elevated liver enzymes, and decreased platelets. So for all these, the brief review of management of preeclampsia is as follows. Number one, that it is important that you must admit this patient in an ICU or high dependency unit with a multidisciplinary and multi-speciality involvement of all the senior consultants, hematologist, senior oncologist, senior hematologist, anesthetist, and senior gynecologist, obstetrician, senior midwife, and then ICU specialist, and then you have to control the blood pressure. There are a lot of options. Before Eldomet, centrally acting drug was the methyl dopa was the drug of choice. But now these are very good drugs are available, though they have some side effects like nitronol, hydralazine. This is a centrally acting drug, and another drug which is labetalol, alpha-1 beta-1 antagonist, and nifedipine, which is basically a calcium channel blocker. So all these drugs, they can be tried to control the refractory or uncontrolled hypertension. That is most important. Second thing is that since the patient is having fitting seizure convulsions, to stop these convulsions, before the diazepam was the drug of choice like lamotrigine, rivotril, all are from the phenytoin. They are from the phenytoin is an epileptic also, and before that this diazepam was all lamotrigine and rivotril are from the benzodiazepine series. So, but now there is an excellent drug of choice, and which is the gold standard, and this is injection magnesium sulfate. It's a very effective drug. You can imagine that with the diazepam, it has got the efficacy rate of controlling the fits and the general condition of the patient by 55 to 60%, as with proved by the greatest trial, Eclampsia collaborative control trials and others. This is very effective drug, but it is a very toxic drug as well. So it has safety margin has to be kept in mind. Its toxic levels should be monitored, and clinically it is to be monitored by the reflexes like knee jerk, ankle jerk, and renal output, and the respiratory rate. Since I have told you it can cause respiratory and cardiac arrest, so one must anticipate that it can happen, these arrests can happen. So we must be in hand at the injection calcium sandose, which should be given immediately. That is the life saving one. And last of all, important thing is that it has to be delivered. The eclampsia patient has to be delivered in 6 to 8 hours. That is most important, because all the triggers, autoimmune triggers, antioxidants, and all those chemical factors, they are coming from the placenta, going to the circulation in the neonate and the maternal circulation, neonatal circulation, causing the vasoconstrictor tone, increasing the vasoconstrictor tone, bringing all about these changes. And in the preeclampsia, second wave of trophoblastic invasion is also impaired. So delivery is most important, 6 to 8 hours, and luckily these patients are very effective, and these patients are delivered very early, naturally. But you can induce them, and then if you see, and if it is delayed, then you can take the help of elective C-section. So this is a brief review. We will talk about later on also. The takeaway lesson is pray, praise, trust, love, worship, talk about Allah, and follow the Asna lifestyle of Hazur Sallallahu Alaihi Wasallam, which is our health and survival. And also we must not forget the glorious Muslim past. दो नीम इनके ठोकर से सहरा और दरिया सिमट कर पहाड़ इनकी हैबत से राय. Thank you very much. वमा अलैना इल्लल बलाग.